Hello and welcome to today's webinar, Maximize Your ROI on CMS Payer Mandates, 10 Key Questions. We are very fortunate to have with us today Stephen Burko, Senior Advisor for Value-Based Care, and Julie Smith, Senior Product Manager of HealthShare, both with InterSystems. Stephen brings to today's conversation over 2 decades of experience as an executive and GM for both plan and provider organizations, and Julie brings a unique combination of IT and clinical experience, having started her career as a frontline nurse and then nurse director. At this time, I would like to turn the floor over to our speakers. Welcome.
Thank you. I want to start off by just thanking everybody for giving us an hour out of what I know must be a hectic Monday. On the screen, again, the focus of our remarks today, we're going to be exploring how do you best maximize your ROI on CMS payer mandates, and more specifically, the IT infrastructure that's effectively required by CMS's recent rule 0057. And hopefully reserving the bulk of our time to move through what we think are 10 really important questions that health plan leaders should be thinking through now to be able to maximize this investment. Before we dig in, just a quick legal note. If you go down at the bottom, we've got our legal note, which is just keep in mind that this material is for informational purposes only. We are not licensed lawyers, and please do not construe it as legal advice, even though we are going to be talking a good bit about a federal rule today. Clicking into the whoops. We're going to get this. Here are the 10 questions. We just wanted to put them up front. Our game plan today is to spend maybe about 10 minutes just providing some general background on the rule. And then we literally want to walk through these questions one at a time. Julie and I will be talking about them. And our aim is to hopefully preserve at least 10 to 15 minutes at the end of the call to address whatever questions you have. So as we go, please feel free to start populating your question field, and then we'll try to get to them, as many of them as we can. Right now, no need to start reading through all these questions at hyperspeed. What I really want you to just take away from this is the 3 larger buckets. So organizational and IT infrastructure, operational processes, and end user deployment. As we get deeper into the rule, you're going to see that there's a lot of things that go far beyond just technical infrastructure. And so to maximize that ROI, we've tried to bucket these questions in a logical way to move through due diligence. So first thinking about, what is the infrastructure I have at my own organization, and then operational processes, really important. How are these going to impact our processes? What new processes do we have to start thinking about putting in place and or tweak to maximize that ROI? And then ultimately, I'm not sure we're in a field of dreams situation. I don't think necessarily just if you build it, they will come. So we really have to start thinking through to really maximize those ROIs. We have to get our end users to deploy this. And how do we build this bridge in such a way that people are going to want to walk across it? So Julie, I don't know if you wanted to add anything for your aims for the hour.
Yeah, I think that's a great characterization of some of the questions that we're going to go through. The reality is that an effort of this size really requires setting it up for success from the onset. And so I think, the way that we've bucketed these is sort of staging this out and acknowledging from the beginning that we really have to think about who our stakeholders are, which I know we're going to get to, but really how to get this to success means everybody in the organization has to be involved, because it really does touch processes, infrastructure, and then ultimately those end users as well.
Okay, so everybody buckle up. We're going to do our high-speed tour of what is an 800-page regulation. So first, just some numbers to quantify the ROI challenge. What you see here are actually results from a recent Gartner survey of 46 health plan leaders. And on the left, we've graphed out what they rated as their top 5 most important payer initiatives in the year ahead. And if you start to kind of move left to right on the bottom, I don't think there's any big surprises here. Obviously, want to positively impact quality initiatives. We want to leverage data and analytics to advance the triple aim, and so forth. I think what's really interesting is if you tweak the question when you move over to the right and now ask, what are the most important factors which are actually influencing these big decisions? Going down to the bottom again, what pops to the top is regulatory shifts, which again, probably not too big a surprise in light of how heavily regulated the healthcare industry is. I mean, it's pretty interesting. It's actually, if you follow the lavender and blue, it's the only factor that every respondent rated as either very important or somewhat important. And I think this kind of represents our challenge. Obviously, we are trying to accomplish big aims, but we have to be sure that we are meeting regulatory compliance, obviously stay in business, and to do the right thing. But I think with regard to 0057, I think this is also our opportunity. And what I would suggest is that the infrastructure that 0057 is effectively mandating that health plans put in place or invest in, it is exactly the type of infrastructure that we need to drive the triple aim and reduce provider abrasion. And at least so far, we don't see a big delta between the investment you need to make to get regulatory compliance and the investment you need to make to actually drive those larger aims, as long as you think it through on the front end. And that's effectively what we want to do a lot today. The next slide is just kind of a 100,000-foot view of what 0057 comprises. I want to call out 4 things about this slide. Number 1, so if you go in the middle, it talks about what everybody, I think, gravitates to, the information sharing, the API. The APIs, the 4 of them. But up at top is kind of the end users of this. And I think one thing that all plan leaders have to keep in mind, 0057 is just not obligating you to support APIs. It's actually building an API where you're also the end users, and that is the other payer. And that it is, in effect, requiring the sharing of information, clinical information, that is critical to effective care planning and care management as members move from plan to plan. So a real opportunity here if you embrace the fact and remember, hey, we're also in effect the other payer. The second thing is, the first 3 kind of information sharing I had there, there's what is known as the access APIs, and that 4th one, prior authorization, it really is different. I've tried to suggest this by calling the first 3 data sharing and the 4th data exchange. And so when people start to fixate on prior authorization, there is some merit there, because the first basically entail more of a unidirectional sharing of information, query the API, get the information back. Whereas what is being required with prior authorization is almost an ongoing exchange of information. So bidirectional, so it introduces a lot more complexity. Kind of moving my way down, just also take note that we have some white boxes there, or light blue boxes there, business and operational requirements, reporting to CMS. Just keep in mind, it's what we've already alluded to. There's a lot of stuff embedded in this rule that talks about how processes need to happen or change. There's some reporting requirements. It's not just about supporting the API. And then finally, along the bottom, for those of you who've been reading about 0057, you've probably bumped into this concept that there's an implied 5th requirement, technological requirement, and that is the longitudinal health record. And the reason why people talk about that, and again, it gets back into this huge opportunity, is that if you look at things like the payer-to-payer data sharing and the prior authorization data sharing, it's not just about exposing information from the plan to the provider or the plan to the member or the plan to another plan. It's also about capturing clinical information that not only that you can affect leverage along with whatever you're getting from HIEs or any other information to kind of advance those goals of value-based care. But that's only going to work if you have a place to put it where then you can then leverage it for all these other positive uses. One other good piece of news here when we start to look at 0057 is it is building upon other investment. We're not starting from scratch here. So lowering the bar a little bit in terms of what we're going to need to achieve to really maximize our ROI. And what I'm talking about here is that there was a prior rule known as 9115 in 2020, and that introduced an API for patient access. And if you look at the slide on the screen, top left, those 3 bullets are all data requirements that every plan serving with impacted products should already have stood up. And then you can begin to see that, at least with regard to the access requirements or the access APIs, that it's building upon what's already been put in place. We're supporting that, other vendors are supporting that. So with regard to the patient access API, dropping down to the bottom, adding the big add here is information regarding prior authorization. And then as you move right, payer-to-payer API, provider access API, you can see that the start point for both of these in terms of the data requirements is, hey, everything you're exposing to your members via the patient access API, you have to expose it to other payers, you have to expose it to other providers, along with, I think, some pretty logical adds and or subtractions, which I will leave for your later review. The next slide are the 2 main effective dates that everybody should be aware of. So the first one is January 1, 2026, and this, to simplify it, involves everything other than the API requirements, other than the things that you have to do a heavy technical build. What I think is important to just note here is not that first row under requirement, but the next 3, and they all have to do with prior authorization. Because remember, this is wholly new API, and you are going to have to start publicly reporting on your prior authorization metrics January 1, 2026. But the next 2 are important. You are going to have to start providing a specific reason for authorization denials, and you're going to have to comply with a time frame that's in the regulation. So specifically, you're going to have to respond to prior authorization requests that are standard within 7 days and expedited requests within 72 hours. So you can already start to feel the push. We've got to figure out a way to automate prior authorization even before the deadline for getting the APIs up and running, which is directly below. It's January 1, 2027. I think everybody is already starting to realize that this is pretty close in light of all the things that must be done to be live and functional by January 1, 2027. The last thing I want to note is the final bar. Actually, this is an effective date not for payers, but for providers, specifically MIPS eligible providers. And starting in January 1, 2027, they have to attest that they at least tried to submit a prior authorization claim electronically via the PA API. And if you're sitting there thinking, that, wow, there's all this stuff in 0057 that payers must support, that seems like a pretty light lift for providers. And that is one thing you do need to keep top of mind here. In effect, what the regulation is saying to providers, you need to at least try it. But this goes back to my point about the criticality of questions around end user deployment, because providers are not going to be obligated to migrate away from phones and faxes. We've got to build a bridge that they want to cross. Now, before we get too far down into the details, I do want to just call out 3 framing concepts to keep top of mind when you're thinking through your 0057 strategy. And the reason why I do that is across the last several months, I've kind of found myself in a lot of conversations where we get so detailed, we lose sight of kind of bigger tectonic forces that we have to keep top of mind when we're figuring out what is the best path forward, what is the right way to maximize our ROI. So 3, number 1, just keep in mind that 0057, that the products, the planned products that are subject to 0057 are what they called impacted payers. And sometimes I think it's easier to not focus on what CMS is calling an impacted payer, but what's not here. And obviously the 2 big things that are not here are Medicare fee-for-service and commercial. Now, I think over time, there's clearly the government is trying to push towards more general adoption, but this rule impacted payers. That's what it is relevant to. The next is the reach of APIs. And just, it seems straightforward, but never lose sight of what an API does is expose an information endpoint. So a third-party app can come in without not detailed knowledge of your payer systems and grab that information for the end user. So sometimes, 2 points, sometimes I'll be with plan execs and they start talking about the GUI for the provider or the GUI, the graphical user interface for the member. And I'm just like, hey, just keep in mind, it's great if you want to help there, but that's beyond the scope of what 0057 requires. And what the government is trying to do is to try to create this data liquidity, this environment like finance has, like travel has, where we can have end user apps designed by third parties that really want to make people cross that bridge with us. And then finally, the recommended IGs. So what 0057 requires is that plans support FHIR-based APIs. Now, in the regulation, they recommend, some would say they strongly recommend, leveraging DaVinci IGs, implementation guides, to build these APIs. And DaVinci is it's a partnership between plans, providers, the government, vendors, in terms of trying to figure this out. And then findings are written up in terms of implementation guides. I will tell you, let me just disclose a little bit of bias here. We are heavily involved in DaVinci. So obviously, we think building these things in a way that complies with the DaVinci IGs make a lot of sense. But for those of you who are familiar with how the government works, you would be right to say that things that are recommended today are often foreshadowing of what might be required tomorrow. So I do want to close out my quick intro to 0057 by at least putting this regulation in context. And so what you see on the slide here is the most relevant regulation that predates 0057, and most likely the most relevant regulation that's going to be finalized after it. So on the left, starting on the far left, this is 9115. It was finalized in 2020. I just called out a couple of the most relevant provisions. So requiring this plan support for a FHIR-based patient access API. It did call for the payer-to-payer data exchange, and it also did call for a plan-supported provider directory API. Then you move over to 2024, just doubling down on what I said before, that in many ways, 0057 builds on 9115. You have the expanded patient access API. With regard to the payer-to-payer, this is actually a swap out. It sets aside what was called for before and updates it with a FHIR-based payer-to-payer API, and then the addition of the payer-to-payer API, then the addition of the provider API, and of course the addition of the prior authorization API. I think what people have to keep in mind, though, is CMS and ASTP ONC are not done. They've clearly communicated they're going to continue to push on rules and regulations that support, that promote healthcare's move to a FHIR-based interoperability. And the one I call out here is HTI2. If this is something that hasn't hit your radar screen, it's something you should start to really be aware of. A couple of things I'll just top line here. Number one, note that in contrast to the first two, which were CMS regulations, this is an ASTP ONC regulation or proposed regulation, which means that ONC regulates the certification program for health IT. So that's really what is at issue here, at least with respect to building off of 0057. The top bullet talks about how they are expanding the health IT certification for provider health IT. In effect, if you get into it, now saying, wait, if you want to be certified, you have to comply with those Da Vinci IGs. And whoops, I got them backwards there. I was talking about the lower bullet. The upper bullet actually introduces a new certification requirement for payer health IT. Again, saying, you know what, if you want to be certified payer health IT, you have to follow the same set of Da Vinci recommendations in 0057. So something to keep your mind on, because it seems like we're going to keep going here in terms of pushing. And I think also it gets back to our larger point, again, with bias admitted, that as you build these things out, I think you want to be thinking about how do you build these things out in a way that they follow the Da Vinci IGs to maximize your ROI, because of course the last thing you want to do, or the thing you want to minimize, is rip and replace. You want to build something you can keep building on as the world continues to evolve. All right. That ends my high-speed tour. Julie, we're just running 2 minutes behind our target times. So let me keep pushing. I'm going to go into our first set of questions. Just a reminder that our first set of questions, organizational and IT infrastructure. And the first question up, question number 1, what groups or team members in your organization will own implementation and rollout of your APIs? And do you have cross-functional work groups and or meetings in place to optimize their collaboration? And what you see on this slide is just some data suggesting why this question is so important. What's graphed here is the percent of health plan leaders at a pretty broad cross-section of plans across the country. What percent of them actually rated the roles listed below as among the 3 most influential in investment decisions regarding FHIR APIs, prior authorization, and longitudinal health records? And just a couple of things I'll call out here, and then I'm going to tap in Julie. Number 1, the bar on the left, the one bar that kind of scaled above 50% had to do with the clinical leader, not an IT or a data leader, which again makes some sense because we're talking about really bringing in clinical data. I think perhaps the more critical thing to call out is even that one only just got above 50%, and nothing else got anywhere near 50%. There's just a lot of cooks in this kitchen that if we're going to optimize ROI, we got to figure out how we're going to work together. And I know Julie's been living this data as she's been working with our partners to get their strategies in place and get going. So Julie, I'm really curious in terms of how this is manifesting in reality and how are people addressing it?
Yeah, I mean, I think this is a fascinating question, and one that really does have to be asked early on. I have the privilege of talking to health plans on a very, very regular basis. And this certainly reflects my experience. We certainly see in this world of CMS 0057 particularly, that organizations are coming from a multitude of different siloed departments. And what I actually have encountered at times is the idea that I'm actually the one that says, do you know, I'm actually talking to somebody else at your organization as well. Because these really work in parallel and have historically been thought of very often as either IT projects, regulatory projects, maybe clinical projects, right? So, or certainly the level projects. And this is the time that these need to come together in order to create a true vision for what's possible, but also having everybody that's appropriate at the table. And this is a regulatory driven issue where many organizations start, but it quickly becomes something so much more. And I know we're going to talk about that in some of those other questions that we get to, but this is really cross-functional. Many of the places that have data repositories and then have some clinical work and then have some ID departments, this is the opportunity to bring everybody to the same table to think about what it is that we can do to get the right questions answered, to set up a plan for success. And it encompasses everyone on this list to be able to do that. You want to go on to the next slide, Stephen? I think we're going to continue to build on that to say this is not just an IT infrastructure issue, but it's truly an organizational structure issue. So when we think about question number 2, what systems are in scope for your electronic prior auth deployment, and can they communicate electronically? This really gets to the heart of the way things are done today and the way things will be done in the future, and the opportunity to say, what does the future look like? And I know, Stephen, you want to dive in a little bit further there.
Okay, so Julie's teasing me because she knows this is like my favorite slide. I keep talking about it with people. And what it shows is not just a blueprint for 0057 compliance, but I really think what's in the head of most people when they talk about how are we going to fully automate prior authorization from the reality that we're starting from. So what I want to do is I'm going to just go pretty quickly left to right, discussing what's in the graphic and talking about what is actually relevant to reaching this reality and what's actually in scope or what's regulated under 0057. So let's start over on the left on the provider side, and we're going to zero in on the relevant provider systems. And both the rules are clearly we're making a clear statement where they want to go, and they're making that statement because, I mean, at least the roundtables that we're at with all sorts of different providers and provider organizations, they have made clear that they really want prior authorization to be within their EHR workflow as opposed to other provider portals. So we have these EHRs. Now remember, all this is outside the scope of 0057. HTI2, though, is now saying, well, if HTI2 is finalized as written, that to be certified health IT for providers, that health IT will have to support Da Vinci-based APIs. Okay, those Da Vinci APIs, in effect, then will be able to communicate with the Da Vinci APIs that you all have to support payers under the rule. So first thing that you have to think about is even if the rules are saying on both sides, you have to have Da Vinci-based APIs, we still have to think about who is intermediating this conversation between the provider side APIs and the plan side APIs. No regulations on that yet. What I can tell you in our experience is kind of first movers have tried to do this point to point. So one plan trying to intermediate with an EHR from one provider. And this is very cumbersome, and there's increasing recognition that the real challenge here is who and how are we going to do this intermediation at scale. So everybody on the line should start thinking about, am I going to use a QHIN? Am I going to work with my dominant EHR? How am I going to figure this out? Then we go to the center. The Da Vinci-based APIs, that's the APIs that are subject, that are in effect mandated by 0057, the things as payers, or at least impacted payers, you got to support, and they got to be live a little over 2 years from now, but a lot to do. And part of why there's a lot to do is moving right. And we move beyond the scope again of what's required by 0057. As payers, you got to figure out how to get all this information into your Firebase standard. But there's recognition in the rule that a lot of your legacy systems are, one, not in Fire, and two, there's still a lot of people running around the blue box to the right. So I think there's 3 systems that I want to call out, larger system categories that I want to call out. When you're thinking about what are your systems running across the top, you should be thinking about what are the systems that are going to be touched to answer the question for an individual PA request, is a PA required? Member eligibility. contracted coverage. What does the contract say? And obviously provider status, which I think historically wasn't as complicated, but with the profusion of providers who are being gold carded, how well are your systems capturing that? Is it in machine readable language? Next set of systems, kind of bottom left of that blue box, our systems, specifically how codified are our clinical rules and how automated is the translation of those into, here's the rules, we know what they say, now we have to apply the rules to actually the submitted information, utilization reviews. Many plans we work with, those are different systems. And finally, going back to what we already alluded to before, how robust is your longitudinal health record? Because we want to increasingly be able to leverage the information that we are getting. All right, this brings us to our third question. Question 3, can your systems incorporate retrieved clinical data into a single longitudinal health record that normalizes and harmonizes the information? So again, if you start at the bottom of this graphic, we're trying to illustrate how, at least with regard to the Access APIs, we're building off of 9115, but remember, part of the big promise here, if we're not just trying regulatory compliance, but we want to maximize our ROIs, is taking advantage of the inflows into the longitudinal health record. So Julie, I'm going to kick it back to you to talk about if you really want to have what we call a robust longitudinal health record, what's really needed to advance the value-based care use cases at the top.
Thanks, Stephen. So, this gets to really the heart of the matter. As they mentioned in the intro, I'm a nurse by training. I've been around long enough to have documented on paper, done chart audits on paper, chart chases all the way through. And this is game changing when I think about the prospects for the future. So, what the CMS regulation says here is that you have to collect your data and have it available, but it takes it one step further to say, and it should be a single longitudinal record for a given member. And when we think about what does that mean, we're saying, well, you could just have a data dump, but really to make this useful in value-based care, useful across population health, chronic care measurement, gap closure, right? All of these things that you do on a daily basis, you really need to have what is truly a system and a tools in place that do things like normalize the data, deduplicate the data, standardize the data, where you know that no matter what the source is, that you ultimately get to a very clear clinical picture of each of these members, because then you can do things with it that you may be doing on paper very manually today. And those things are really significant from a ROI-based perspective. Because when you think about HEDIS measures, when you think about risk adjudication, when you think about population health management, it is when you have that clean data in a longitudinal record that you can drill down to the individual and you can pull it up to the analytics side and really find the answers to many of the things that you do today through other more expensive processes. And so that really says, you got to feed it in, right? And you got to get that entry point. But when you clean it up, that's when it really opens up that opportunity there. You want to go on, and we're going to sort of shift gears a little bit to say, so we have, talked about some infrastructure pieces, both IT related and organizationally, but this is really operational. When we've thought about who those stakeholders were that we engage with, you really have to think about what are all of the impacted operational processes. And that gets us to question number 4. Next slide. So on question number 4, we're going to sort of start back at the beginning there and say, how will you match member identities for exchanging data with other payers? Stephen, you want to take this one?
Yeah, so just a side note, we are getting lots of questions in the Q&A of, is the recording and slides going to be shared? So we're actually doing this for AHIP. So I know the recording is going to be shared with the video, and I'm pretty sure the slides will be posted too. I think it takes AHIP maybe a day or two to do that, but the big answer is yes. So if you were furiously taking notes, relax and hopefully just enjoy our effort at giving you words of wisdoms. I just got to know. Yes, the recording by the end of the day. And I'm getting notes from AHIP. And if you want slides, query AHIP, and they should be able to get the slides to you. All right, back to the question. Question number 4. How will you match member identities for exchanging data with other payers? If you drop down to the graphic, we actually cheated a little bit here, and our answer is a little bit broader than that. So we really at least wanted to call your attention to kind of things that, again, should be top of mind in terms of if this is going to work, there are workflows that are going to be impacted. So starting on the left, member opt-in. So this is specific to payer. The government recognizing that this is kind of newer for your members. So members are actually going to have to opt in, say yes to you may request this information from a prior or concurrent payer, which again, we want because it really helps us in terms of care management with our new and more complicated members. But you can't do that unless members say yes. On the other side, far right, information updates. If you start to do the math in your head, especially for concurrent members, this can get pretty complex pretty fast because the government's saying that it's not just a one-time exchange of information for concurrent payers who opt in every 90 days. But where I really want to focus is on that middle thing. It's why this question is so important. And it's not just that, you have to identify who the previous or the concurrent payer is. The real challenge is embedded in that first bullet. You actually have to align their member IDs, right? There is no national universal health plan ID for members that we all use. So we've got to figure out a way that we understand the way we're identifying this member. That's the same number that we're requesting from the other payer. And just note the bottom bullet as well. If somebody opts in, this is not optional, that you must, as a plan, request the information from all identified payers basically within the 5-year window that the member was asked about. I'm going to skip the note at the bottom of the slide due to time. And let's move on to some operational considerations relevant to prior authorization. So question 5, how will you automate data exchanges between your PA, prior authorization API, and clinical rules engine? So we're digging deeper into that blue box in terms of our blueprint for electronic prior authorization. What you see on the slide is an illustration of what the workflow should look like under 2 Da Vinci IGs, DTR and PAS or PAS. If you're unfamiliar with that, there's something known as the Da Vinci IG, informally trifecta for PA, and I call that out on the right. The DTR and the PAS or PAS IGs explain how this should flow once the determination has already been made that a prior authorization is required for this service or procedure. And going down the middle, it's just a representation of, in effect, how it's supposed to work. What I want to call your attention to is that box on the right. And again, we're trying to think about, wait, that's great. If this is how it's going to work, what does this mean in terms of our internal processes? How's this going to work? And I'm really now double clicking on that set of systems that inform that decision about, hey, is this prior authorization going to be approved, denied, or pending? And for the IT people in the room, going back to Julie's initial point that a lot of the payers that we've talked about, these functions are siloed. The one thing that we've learned time and time again as we work with payers, that we have not confronted one payer yet that has one clinical rules engine. They have at least 3. So for IT people on the phone and you're thinking about what are you going to have to automate, you need to ask after all 3 of these. Your plan most likely has a set of proprietary rules. It has a set of license rules, most likely either from Interqual or MCG. And then there's also various services that have been delegated to often smaller third-party vendors who have expertise in a specific area, so like behavioral health. So when we start to think about how are we going to make this all work, I mean, just simply on the front end, the first thing is ideally we're going to automate some sort of broker when something comes in, which set of clinical rules and or decision makers is this going to point to? Happy to go deeper in Q&A, but I did want to underscore here that it's not one set of clinical rules and one process. There's usually at least 3. I think we just have 2 more operational questions. Okay, question 6. So moving back from prior authorization to provider access API in particular, question 6, what data or existing processes can you leverage to attribute members to new providers? Question 7, what safeguards are needed to prevent sensitive information from being wrongly shared? So again, we're just trying to call out things you should think about now, keeping the list short, which our clients have asked us to do. I'm just going to kind of run around this graphic. You can see, for lack of a better word, the bullseye's in the middle, right? If you can satisfy all 3 of these, then you can share your records with the requesting provider, which ideally we should want to do. It's going to equip them to better manage the care of that patient. So first, starting at 12 o'clock, it has to be an in-network provider with an established treatment relationship with the member. And I know at first blush you used to say, well, we have their claims. That should be pretty easy to do. Again, remember, our conversation is fixated on maximizing the ROI of this infrastructure. And I would argue to you that one of the best moments to equip a provider with this information is when they're a new provider, and can you get this information in their hands before the first appointment, so the provider can think about the larger issues and how am I going to approach this. And just from a sheer member satisfaction, maybe the member doesn't have to ask the same questions they've been answering for years. Again, a quicker start point. So one of the things we need to start to think through is, how are we going to associate a provider with a member before they've ever seen them? Kind of going around the clock. Here, the regulation requires a patient to not opt out. The government feeling that people are more familiar with sharing information with their providers, going to be more comfortable with it. So in contrast of having to get them to opt in, they just need to not opt out. However, you cannot be silent on the matter. There are requirements in the rule that you provide education to the members as well as the providers in terms of how you utilize this. So again, going to be an impact on your educational workflows. And then kind of rounding out, I guess at around 7 o'clock, I mean, this isn't just about sharing information with providers, but with everyone, right? Legal's going to be involved. We need to consider what are the overlay, not just of the federal rules and laws, but also your state rules. We have to ensure that the system that we're building has the appropriate checks, so we're not disclosing anything that would run afoul of the law. Okay, going to keep pushing, still trying to preserve some time for Q&A, and that takes us to our final set of strategic questions, and these are end user deployment. If you joined late, you might have missed, Julie had a prior career as a frontline clinician. So I'm going to turn it back to you, Julie, to bring us home in terms of this set of questions.
Yep, absolutely. Let's go ahead and to the next slide. So here we go with the end user impact, right? So question 8, what tools do frontline staff need to act on data from other payers to improve care continuity for new and concurrent members? And then sort of alongside that, we're going to say, how can you help your provider partners benefit fully from information accessible via your provider access API to achieve mutual goals? And this is where we can really think about and acknowledge that at times there is friction between payers and providers. And this is a key opportunity to say we can do better together. And when we do better together, what does that look like? And that requires collaboration, that requires engagement, right? All of being on the same page and on board. And it really requires a partnership, because at the end of the day, the intent here is value. And when you think about value, what you mean, what is required on that is access to the data. So much of what we've talked about thus far is the pipes, sending data here, there, everywhere. And now what we're talking about is true impact. What do those frontline staff need? They need access, and they need access to that really clean longitudinal record in order to be able to deliver better care, and in order to be able to process prior authorizations faster, in order to be able to then ultimately, right, do a lot of the value-based care actions that are done manually today. And how do you facilitate that? It really is by creating an environment of trust in the tools, following, Stevens mentioned Da Vinci standards and things like that, but really saying we're all in this together. We are all on board. This is the processes we follow in order to get to an aligned goal in a faster, more automated way. And specifically, when you think about that provider access API, that gets us even a step further to say, to Stephen's point on the diagram, to say, providers, if you have the opportunity to actually get information about your patient before you ever see them from your payer, that opens up a lot of opportunity to deliver better care. And so that really can matter. And that is our true mutual goal in really making patient lives better. The next slide. So that gets us to what is question 10. And this one I'm going to pull back and focus on prior authorization again, and think about what steps in your prior authorization process account for the dominant share of provider abrasion, and how can you best leverage your investment in prior authorization to streamline provider workflows for these touch points. Right? We hear very consistently from the provider organizations we work with how challenging at times the prior authorization process is. We also hear from the payer organizations we work with that it is challenging to keep up with all of the rules and processes and all of the expectations involved. But one of the true stated goals of the regulation is to reduce provider abrasion. And so then when we think about where are you going to get this value, Stephen and I have had this dialogue back and forth on, if you have 100 pennies and you have to make a call on where are you going to get the most value? Is it going to be in the clarification of whether a prior authorization is even needed? Is it going to be in the specification of what documentation is needed to process that? Is it going to be in the sort of submission process around the required documentation, or is it actually in the ultimate rendering of the decision? And we've talked about it from both of our perspectives, and me certainly coming from the clinical space and also participating in a lot of active work around a lot of pilot projects and engagement for EPA. I would lean towards the idea that very first bucket, clarification of whether a prior authorization is required, I would probably put about half my pennies there. And the reason I would do so is because our research so far and the experience we've had thus far across the industry is that actually about half the time providers ask for a prior authorization request, it's not needed. And so even if we could just solve that one step, we have already reduced abrasion. And then because that sort of capturing of all of the data needed on the clinical side is a challenge, I might put 30 of my cents there. And then I just break it down further to say maybe, the last 10 and 10 in the last buckets. But Stephen, I know you have a different thought, certainly coming from all of your years dealing with provider abrasion experience overall. So tell us your thoughts.
Yeah, so for those people who don't know, I've spent a lot of years working with organizations, specifically not just provider engagement, but physician engagement. And so it's interesting because, Julie's right. I mean, it's remarkable when we start to audit this stuff, how many PAs weren't necessary. So it's a huge waste to have to run them through the whole process. Much easier if we get it quick, we can just stop it right here. But again, I am so fixated on, at the end of the day, we've got to get many still physician-led practice groups to play ball, to be willing to change their own processes, to move away from fax and phone. And at least my experience with them is a lot of that determination of whether a PA is required Number one, a lot of specialists already have a pretty good gut if they're in a specialty area. And I know that is kind of counter to the fact that yet 50% weren't necessary. But also a lot of this is actually not handled directly by the practitioner. And I know that a lot of them express their frustration to me around the roundabout of the specification of documentation required. They start to feel like they're on a carousel. And it's like, wait, what else do they need? What else do they need? And they kind of feel like, they're pitching blindfolded. So I tend to, as a start point, to put more pennies there. But I think the larger point is what's, number one, there's room for debate. And I'm not sure if there's a national answer. It might be dependent upon kind of the culture and the geographic regions of your individual practices. And it's why, I think it is important that you get the right people in the room and you sort this through, because all too often I've walked into rooms and again, you get so far down into the detail that yes, we're going to, what's the point of, we're going to build this investment. And what is clear, if you can get even incremental movement in terms of away from faxes and phone for prior authorization to using the automated process, you can have a multiple X return. But we got to get people to play ball. We got to get people to want to do this. So be thinking about, it's not just about compliance, it's about getting providers to want to follow this and what is most meaningful for them, because they're only required to try it under the rule. Same thing if you think back in terms of the payer-to-payer stuff. Great opportunity, but the rule is requiring us to expose those information points to each other, plan to plan. But as plans, if we want our own care management staff to take advantage of it, we have to start talking with care management about what do we need to support from an IT standpoint, that the tooling necessary for your care managers, either at a micro level or a macro level, to change care based on the information up front we're now getting on all these patients who are churning through the system. We are fast running out of time. We've got several questions, so I'm just gonna, I'll come back to this slide in a second. We got a number of questions about InterSystems. There's a slide at the end here. Many people joke around that, we're everywhere and yet people aren't that aware of us. We have a huge footprint. We support Epic. But on the right, you can just get a sense of why we're so passionate about this. Second bullet, yes, we do a lot to support your regulatory compliance, but actually where we're really trying to do is to help you leverage IT to make care better. So just, if you're curious, just request the deck. Here's all the different things we're helping. Let me step back. This is all the questions. And you're like, well, wait a minute. I thought we did 10 questions. Why are there suddenly 20? If you really want to geek out, we've written a whole white paper on this. If you want to go deep without going to the full 800-page rule, there's a link at the bottom. You can also go on the InterSystems website and just Google maximize your ROI. This should pop up. And we actually isolated 20 questions, and then we got a lot of feedback from plans about, well, it's still a lot of questions. Can you scope it down? So what's highlighted there is the questions we covered today. If you're focusing, yes, we cheated. We actually did 11. We combined 1 and 2. I will acknowledge that up front. I think the thing that I think was a really smart push that we've gotten from our partners is, InterSystems, it would be really helpful if you stop bucketing everything. Here's questions by this API. That's not how we're going to stage the effort. And it is important that if we're going to maximize the ROI here, we don't work in silos. So I hope it was helpful today, our effort to take both a slimmer version of these questions and think about them more in terms of how the work needs to get done than just an artificial, okay, this is this API and this is that API. With that, we did preserve a little bit of time for questions. So I'm going to try to just, Julie, I'll start reading some and you start reading some. So one, how does CMS 0057 DTR contemplate AI-based solutions for answering the DTR? And that is a great question. And I'm being a little bit cheeky because there's lots of comments and it's a huge rule. But at the end of the day, 0057 is basically saying, plan, you need to support a Firebase API. And this goes back to what I'm talking about. To populate that API, the plan is going to have to translate a lot of information from other systems into that Firebase API. And I think if the government was on the line, they would say, we're not trying to curb your creativity on that. Actually, we recognize there's a lot to be figured out here, but we're encouraging you to automate as much of that those back-end systems. And I know there's a lot of conversation about the potential for AI to actually adjudicate prior authorization claims, but you're neither hemmed in nor forced to do stuff on AI under 0057. I don't know, Julie, is that your read of the reg too?
Yeah, absolutely. And I would say, the thing that it does call out is this is not a special snowflake. So the expectations around AI in using clinical data are true for this like they are for everywhere else. So AI is not automatically excluded and AI is not required, but in the event AI is used, it does have to follow all of the standard requirements for AI solutions across the board from the government standards. And those are generally available on their websites, but just to be clear on that. And we certainly see a lot of experimentation in this, because there's a lot of opportunity here.
All right, so here's another question. This is a great question. So I was just out at HL7, and this actually came up in a discussion group. So the question is, could you confirm if prior authorization is delegated, the plan can or cannot say you must submit this PA to the delegated entity XYZ? And the question came up a little bit different. Like, wait, under 0057, if you're using a third party, like say for behavioral health, to adjudicate prior authorizations, are you plan subject to 0057? Or can you say, hey, with regard to this, it is the delegated vendor's obligation to comply with 0057, and I'm just referring you to the delegated vendor. And look, I think we need to be careful. You're not going to really know the answer to these things unless there's a government advisory letter or it goes through an administrative law claim. But at least the wisdom in the room was no, plan, you can't have an end around by saying we're using a delegated vendor. So to more directly answer the question, the plan is obligated to comply with 0057 in terms of providing those endpoints with regard to prior authorization. Now, how the plan decides to determine what information must be submitted and how that plan is adjudicated, that's beyond the scope of 0057. Julie, I'm just going to kick it back to you because I know it's a long rule and we've read it together. Is that your read as well?
I absolutely agree. Yep. I've certainly heard that in a number of forums. And again, it is ultimately the plan's responsibility, no matter who the vendors of choice that they use to meet those requirements.
So Julie, I got a question for you because I know you're getting it every day. And not just as a question, but building out timelines. So great question. What would you recommend for a decision and or implementation timeline for 0057? How quickly do I have to be working through this stuff?
Yeah, so the answer is now, but what does now really mean? So we certainly see a lot of buzz in the market, and we have moved beyond typically as an industry from understanding the rule and understanding what the regulation just says to saying how are we going to go about this, and in that process of how, right, you typically have a lot of conversations. Are you going to build it internally? Are you going to use third-party vendor? What are our existing systems? All of those things. What we see is that many payers are taking a look at what solution they have in place for 9115 and saying, can that solution, whatever it may be, meet my long-term needs now that we can see the writing on the wall of where this is going, right? That was that entry point, but now it's really becoming a more robust, not just file repository, longitudinal record, and we can see with HTI2 that it's going to become something more, right? And so to say, this is the opportunity to just evaluate what's available in your existing system and then make those decisions around what your path is going to be. And when I say that from a timeline-based perspective, we have a lot of ongoing conversations to say, now is the time to evaluate what your options are and to make those decisions sometimes by even end of year, if not by the first quarter of next year, because it takes some time to implement. And when these regulations go into effect, right, those first ones are January of 2026. And this is optionally big. And so you've got to set the things in motion to prepare your organization and understand what technology you're going to use to solve it quickly, to then get on that implementation path for success.
So I apologize, we're at time. I've got a slew of questions I'm not going to be able to get to. So if people have questions, please go ahead and just type them in. I believe AHIP will give us a list of all the things we didn't get to, and either through AHIP or directly we will reach out to you with answers. So please go ahead, use it liberally. You will get a custom fitted response just for you. And with that, I want to thank you all for giving me an hour of your day and turn it back to our moderator.
Thank you to our speakers. Thank you for the great presentation and for sharing your thoughts. Thank you to the audience for participating in today's webinar. This concludes today's presentation. Thank you again and enjoy the rest of your day.